Good afternoon, everyone. I'm Catherine Gaston. I'm a perinatal consultant with the Champlain Maternal Newborn Regional Program, or what you may have heard as CMNRP. CMNRP is a regional program whose goal is to improve perinatal and newborn care in Ontario Health East. Our extended network include representatives from hospitals, midwifery practice groups, public health unit, community health centers, birth center, and other community agencies that provide perinatal and newborn services. Today, we are happy to collaborate with Dr. Jasmine Gandhi and Beth Tupala for this third webinar, part of their Ask Masi webinar series called Let's Talk About Depression. I would like to begin the webinar by acknowledging that we are meeting on Aboriginal land that has been inhabited by Indigenous peoples from the beginning. As settlers, we're grateful for the opportunity to meet here, and we thank all the generations of people who have taken care of this land for thousands of years. Long before today, as we gather here, there have been Aboriginal peoples who have been the stewards of this place. In particular, we acknowledge the traditional unceded territory that our CMNRP office is located on, and that is the Algonquin Anishinaabe people, and our Kingston office, which is located on the traditional territory of the Anishinaabe and Haudenosaunee peoples. We recognize and deeply appreciate their historic connection to this place. We also recognize the contribution all Indigenous people have made, both in shaping and strengthening our communities in particular, and in our province as a country and as a whole. September 30th is coming soon, and each year on this day is the National Day for Truth and Reconciliation. This day honors the children who never returned home and survivors of residential schools, as well as their families and communities. The orange shirt is a symbol of the striping away of culture, freedom, and self-esteem experienced by Indigenous children over generations. On September 30th, we encourage you to wear orange in honor of the thousands of survivors of residential schools. We are happy to announce that this webinar will also be presented in French on October 4th, 2024, from 12 to 1 p.m. Parlons de la dépression. This webinar will be presented by Dr. Valérie Giroux, and we will make sure to include the link in the chat box to share with your colleagues if you want to register to it. Before we get started, I simply wanted to remind you that this webinar will be recorded and that the video will be available on the CMNRP website in the coming weeks. We also invite you to put your questions in the Q&A sessions, as we will, at the end of this webinar, take questions and hopefully answer all of them. Now, without further ado, I would like to present our speakers for today. Beth Tupala is a registered nurse with 15 years of experience. She has worked in 3 different provinces, and prior to her work with Ask Masi, she was involved in opening and operating the first hospice residence in Nova Scotia. Beth is currently completing her MBA at Carleton University and is working towards her formal project management professional certification. Dr. Jasmine Gandhi is the medical director of the perinatal mental health at the Ottawa Hospital and an assistant professor of psychiatry at the University of Ottawa. Her academic focus is on improving equity in perinatal mental health care delivery, as well as medical education and women's mental health, consult liaison, psychiatry, and interpersonal psychotherapy. We also have Christina Quentin, who had previously moderated the first 2 webinars with us at CMNRP. She is now a nursing research scientist at the CHIO Research Institute, and she will be moderating the Q&A session at the end. Thank you so much. With that said, I will leave it to Dr. Jasmine Gandhi to start our webinar today. Thank you so much.
Thank you so much, Catherine. Just in terms of disclosures of financial support, the work that's being done by Ask Masi is supported by an unrestricted grant from Daymark Foundation. And really excited to have everybody here. We have a poll questionnaire that's come up asking, you've heard about who we all are, and we're curious to know who exactly is here in terms of participants. And the various professions that are represented today. I see the poll has come up, and many nurses, about 90% nursing, 11% midwifery, and a social worker that's present here. Well, welcome everybody. We are so pleased to have you joining us. Thank you very much. Our learning objectives for today, at the end of today's session, we hope that you will walk away with the knowledge to describe the prevalence and impact of depression in the perinatal period, to explain the stepped care approach to managing depression, and to be able to at least list at least 2 possible resources or interventions along this continuum, to describe basic management and prescribing principles for depression in the perinatal period, including why it's important to rule out bipolar disorder, and to identify the red flags of depression, and to be able to ask Masi when additional support is needed. So before we move any further, how many people on this webinar actually feel confident in identifying depression? And how confident do you each feel in supporting your patients and clients with depression? If I could get you to answer the poll questions right now, that would be terrific. We'll give everybody a minute to answer those questions. And then Charlotte will kindly pull that up for us once we've gotten our... All right, so that's great. Somewhat confident, most of you, and hence I think the interest in this webinar. A few on the call are feeling very confident, and a few not confident at all. So that's really great in, sort of the case finding piece of that, because that's so important. It's something that we're not doing universally at this point. And then in terms of supporting patients and clients with depression, less people as confident, more people either somewhat confident, or 17% not at all confident. I'll actually just, oh, okay. I'm just thinking that for the recording, we won't see the poll questionnaire, like the results. So maybe we'll just make note of that in the chat if that's possible, without putting anybody on the spot. All right, so let's start with what everybody thinks and everybody says, that becoming a mother is the most wonderful time in a woman's life. And please keep in mind that when I refer to woman throughout this seminar, I will switch back and forth from woman to perinatal individual. Really, we are talking about the childbearing parent for the most part in this webinar, but mean to be as inclusive, and we'll use these terms interchangeably to apply to any gender identity that is a childbearing individual. In fact, that we do know that depression is actually the most common complication of childbearing, and this was said by Wiseman back in 2008, and the data just keeps supporting that claim. So if we go to the next slide, thank you. Why is it important to talk about depression in this period? Well, the consequences for not treating depression is actually quite serious. For the childbearing individual, it can lead to persistent depression or future depressive episodes. There's a high comorbidity of substance use. There are pregnancy complications. Certainly gestational hypertension has been associated in the literature. We don't have it yet, but I would suspect gestational diabetes and hyperemesis would be another one that would be ultimately linked to untreated depression. The babies that are born to individuals with untreated depression tend to have lower birth weight. They may be born preterm. There are higher predisposition to being admitted to NICU, and there are lower rates of breastfeeding. The bonding with that baby, it can be diminished when there's depressive episodes, or altered in a way that's not healthy and leads to an insecure attachment style. That can in turn lead to delays in infant development and long-term cognitive, emotional, and behavioral problems in that child. Beyond actually childhood development, the depression in partners, in the non-childbearing individual, is higher in frequency. So we know that 1 in 5 childbearing individuals will have depression, and 1 in 10 of the non-childbearing parent will actually suffer from clinical depression. It leads to complicated interpersonal communication and couple conflict. And we think a lot about the baby that's being born, but we don't think often about the toddlers or other siblings in the family, and the significant impacts that can have on the parenting relationship with these kids. Untreated depression can certainly lead to child maltreatment, self-harm for the woman, and suicide is actually a leading cause of death in the when we look at maternal morbidity and maternal mortality carried out to the first postpartum year. So it's a really important topic that we do need to look at. At this point, we really define perinatal depression the same way we define depression in other points of life. So a major depressive episode, according to DSM-5, our psychiatry Bible, has to have at least 5 of the following 9 symptoms. So depressed or irritable mood, sleep changes, appetite changes, low energy, feelings of hopelessness, anhedonia, which means a lack of enjoyment or inability to find pleasure in the kinds of things that you would normally find pleasure in, difficulties concentrating, psychomotor changes, so either feeling very slowed or feeling very revved up, and thoughts of not wanting to live. The DSM does make special allowance for the perinatal period, and so the specifier with peripartum onset refers to any major depressive episode that happens from conception up to 1 month postpartum. Clinically, we know that depressive episodes can happen in the peripartum even up to 1 year postpartum. Some people would even argue beyond that time frame, but for technical reasons, this is the extent of the nomenclature at this point in time. So just important to remember that there is no such thing as postpartum depression. That's kind of a colloquial term. When you look at these symptoms, though, it's really hard to think about, okay, well, this is maybe how most people are feeling during their pregnancy. I'll just point out a few symptoms and ways that you can distinguish normal pregnancy symptoms versus something that might be consistent with a clinical episode. So I do find in the perinatal period, especially if there's other toddlers or once the baby is born, women don't have the option to just sit home in bed and pull the covers over their heads. And so they don't have that ability to be really low energy and really, really slow. In fact, what a lot of times ends up happening is that people become more irritable, really, really cranky, losing patience with their partners, with their toddlers, and sometimes even with the baby. They will pull it together for their baby, but they're not necessarily enjoying their baby or enjoying the situation as much as they thought of, even if it was a wanted pregnancy or there's no sort of objective problems going on. They can't find the joy. And those are really important pieces to differentiate from usual pregnancy. Sleep changes, I always ask, when the babies are letting you sleep, when your family is letting you sleep, does your mind let you sleep? And that's a good way to distinguish between being up for childcare reasons or pregnancy related, discomfort and hunger and needing to get up to pee. Again, that appetite, I always relate it back of like, do you feel hungry for food? Do you enjoy eating food? And when your stomach allows you to hold it down, because the nausea of pregnancy or the inability to eat because you're just so busy taking care of kids might interfere with how much is actually being taken in. And the suicidal ideation. So that's a really key point, that if people are having thoughts of, my family would be better off without me, I'm not really seeing the point in living. A lot of times it's passive suicidal ideation, meaning that people are not actually thinking of taking their life, but they're really questioning the value of life. And if they woke up tomorrow morning if they didn't wake up tomorrow morning, they wouldn't feel as unhappy about that. Those are kind of the main questions to elicit something that's of clinical significance versus, you know, the malaise and the discomfort of regular pregnancy and the fatigue of parenting a newborn in a young family. So we'll go to the next slide. Thank you. In terms of how often does this happen? Well, it happens, as I said, to about 1 in 5 perinatal individuals at some point during the pregnancy or the first postpartum year. When we look at antepartum depression, that usually happens, the literature quotes 7% to even up to 12% of people during their pregnancy will suffer from a clinical depressive episode. In the postpartum, that number can be as high as 23% in the postpartum. So it can be sort of the literature quotes anywhere from 13 to 23%. It's important when you're thinking about clinical depression to think about a broader differential diagnosis, because everybody who presents as feeling down or irritable is not necessarily clinically depressed. So the most important one to think about is the baby blues. And the baby blues is almost a normative episode. Anywhere between 50 to 80% of women will experience feeling down, sad, like their emotions are overwhelming them within those first 2 weeks postpartum. Again, this is so frequent that it's almost normative, and it's an adjustment to the extreme changes in hormones right after delivery. This is not a clinical entity, and it is supportive care only, reassurance that this will go away. If symptoms last longer than 2 weeks, however, we then might be looking at something that is more clinical. So baby blues do not last beyond 2 weeks. Another clinical entity called adjustment disorder is something that I want to bring to people's attention. And that's where there is a change in a person's life that causes a reaction that is above and beyond something that we would think of for people from their culture, as a social norm for that person, but isn't actually meeting criteria for a clinical episode. It's still of significance and still can warrant intervention and treatment, but it's important to distinguish that adjustment disorder from a clinical major depressive episode. And then the last thing I'll point out is that 8% of people will actually have not a unipolar depression, but a bipolar mood episode during pregnancy or the postpartum period. And so that's really important to keep your clinical ears out for, to distinguish the unipolar depressive episode from the bipolar depressive episode. So it's 8% overall. And then if you're looking at the people who are experiencing a clinical depression, a significant proportion of them, we don't have the exact data on how many, but a significant proportion, more than 8%, will actually be bipolar depressive instead of unipolar depression. And that's really, really important because the treatments are very different. And if you treat as if you have unipolar depression, you might actually be triggering a bipolar episode. We'll come and speak more about that later. And I'll just mention that whenever you do diagnose a depression, anxiety is probably present as well. They kind of go hand in hand. And we talked about anxiety last time. So if you would like more details, you can look at that recording. In terms of risk factors, having symptoms, even if they don't meet full criteria for an episode during pregnancy, are the strongest predictor of a postpartum depression. Other predictors might be people who've had difficulties with their periods, so premenstrual dysphoric disorder, people who've had a previous perinatal mental illness or have other comorbid mental illnesses outside of their reproductive times, or comorbid substance use disorders. High index of suspicion for those folks. People who have a family history in their first degree female relatives of postpartum depression or perinatal mental illness. People who've been on medication and choose to discontinue it because they're worried about the impact on their pregnancy. and anytime there's poor sleep involved, either during pregnancy or in the postpartum. Those are some of the biological factors. If we look at some of the other factors related to the pregnancy, unplanned pregnancy, first pregnancy, pregnancies that required fertility treatment can also have both psychological and biological impacts on risk. Women who are suffering from hyperemesis, gestational diabetes, and preeclampsia are certainly more prone to clinical depression. Pregnancies where the baby is sick, or there's a NICU admission, or there's difficulties in breastfeeding the child after delivery. From a social perspective, certainly equity-seeking groups have a much higher rate of depression during pregnancy and the postpartum, particularly women from Black and Indigenous communities. So Black communities, the risk may be double, and in Indigenous communities up to even 4 times as much. And also in terms of age, young adolescent, as well as women over the age of 40 are more vulnerable. And certainly people from diverse gender orientations, definitely more susceptible. People with intimate partner violence, this is a high risk period during the pregnancy and the immediate postpartum, particularly for second children. People who are disenfranchised in their social scenarios either have low support, lots of couple conflict, or significant life stressors like a recent move, refugee, immigration, death of a loved one like a parent or even a partner. Perinatal loss is another significant risk factor. So somebody who's lost their pregnancy or had early infant death, people that have lost child custody, and people with a history of trauma. And in the next slide, I go into a little bit more detail about what I mean with trauma. So in trauma, we talk on 2 levels. We talk about adverse childhood experiences. These are your typical, the ACEs that we all think of. And maternal depression, exposure to maternal depression is considered an ACE, as is being exposed to emotional or sexual abuse, being exposed to parental substance use, parental domestic violence, physical, emotional neglect, divorce in parents, parents' mental illness, parents' incarceration or homelessness. But there's also the adverse community environments, things like poverty, discrimination, community disruption, lack of opportunity, economic mobility and social capital, violence in the community, poor housing quality and affordability. All of these are traumatic, either capital T or small t, traumas that build up and lead to one's risk during this period. And I'll just say a little quick piece about trauma-informed care and the 6 core principles when approaching people to ensure that the care that you're providing is in a safe environment, that you're giving voice and empowerment and a sense of choice to your patients and clients, that you yourself present as trustworthy and transparent, that there's a sense of collaboration and mutuality in the care that you two are, the care journey that you're embarking on together, that there's a real importance and value placed on the cultural and historic and gender issues that they bring to the table. And as well, and we'll talk more about this later, the idea of peer support and mutual self-help as part of that empowerment of your clients as well. So anybody that has had risk factors in the previous slides, it's okay to go on to the next one. Thanks, Christina. I just want to remind you that you do want to do a screen, whether that's asking or using a validated screen, which we do recommend here in Ask Masi, the EPDS, and we are recommending screening at intake, at 26 to 28 weeks gestation, and again 6 weeks postpartum. Please refer back to our seminar on screening for more details about this. And if it's a high-risk person, you would want to rescreen at 2 weeks postpartum once those baby blues are done. If the EPDS is positive, and if we could have the next slide, just a reminder that at that point, you do want to rule out a bipolar depression, again, because it does affect the kinds of treatments that you're offering. So the mood disorders questionnaire is meant to rule out bipolar disorder, and we recommend this at any time that the EPDS is positive. And the number one reason being that if you're going to put somebody on antidepressants, and in fact they're bipolar, that antidepressants alone can switch them from just a depressive episode into a mixed or manic or even psychotic episode. And so we do want to be careful that we're providing the right medications, and also tailoring the community resources and therapies that we're offering this patient population. So again, more details from our first webinar. And we'll go on to the next one. And I will actually hand this over to Christina to talk about this wonderful continuum of care.
Hi, yeah, so this is work that the perinatal mental health community of practice has been developing. So it's based on the stepped model for perinatal mental health, but we really wanted to operationalize it for pregnant individuals and postpartum individuals. What does this actually look like? What are the buckets of service? So we continue to try to refine the wording. And I know Beth is starting to categorize the services and supports just to kind of see how that's working with the language. So we just want to show on this graphic that, you know, in a stepped care model, we're situating the family at the beginning, and families actually benefit from care providers and navigation supports, community connectors, whatever word you want to call that in your local area, to be helping to navigate it. It's really hard to understand what's available. We as providers and clinicians, we are always looking to see what's available. So those types of roles are helpful. And we've situated kind of in a fan instead of the stepped care, because we didn't necessarily think they had to step up or step down from a treatment that, depending on what the individual needs, maybe they needed a variety of things at different spokes on the map. So this is a little bit of the work of our community of practice. And, you know, we also couldn't ignore the fact that the social determinants of health are so important. And we've only listed 4. There's many social determinants of health, but sometimes we can't even get to the point of needing talking about mental health support and treatment if we're not actually starting to deal with some of the foundational needs, including addressing the issue of trauma and creating that safety. So this is a little bit of the framework, and we're happy to get your feedback in terms of whether that's resonating with you. Did we get the right words for the programs and services that you offer for pregnant and parenting families? Thanks, Jasmine.
Thank you, Christina. We love that diagram. And I'll hand over to Beth now to talk about specific examples of supports along that continuum.
So as Christina said, I've started to try to organize some of our Ask Masi resources according to these categories. And also, as she said, it's not always necessarily that we would just recommend one or give information about one type of support or resource. So I will often try to give a variety of different things from different aspects of that model or different types of resources. And then as a refresher about what Ask Masi does is we do keep a database. So we have a fairly significant resource database now that we try to keep up to date. And when people reach out to us based on what they are telling us about their client or patient, I try to give some suggestions or a list of some of these resources that they might find helpful and that they can share with their patient or client. So this is an example, as we showed in that diagram, of informational self-help. There are many others out there, but this is just an example of one that it's information that somebody can go online, and that there's this trusted source of information that's evidence-based, that's relevant for where they're located. And so I've provided one example here. And if we go on to the next slide, it's again, some examples of peer support. I think I've mentioned these in previous ones, but they are excellent examples here in the Ottawa area. And the second one actually for Ontario. An example of a psychoeducational workshop, I've presented an example from the Royal and the perinatal journaling that they do. They do other workshops as well, so it can be on slightly different topics, but this is one example from the Royal, as I said. And then in terms of guided self-help, it's similar in some ways and often kind of found together with informational. self-help, but where you might find different workbooks or different modules where a person may actually work through certain exercises on their own. And so this is one example from Best Start. It also exists in French, and I will share this one fairly frequently for people because it is something that they can work through on their own at home. It's CBT based. So I leave that one as an example for you. And then when we talk about therapy, and Jasmine, I think, is going to spend a bit more time talking about therapy and some different modalities. This is one that I'm really excited to tell you about, although some of you may know this if you are within public health, but Ottawa Public Health does have a new CBT program for pregnant people or those with a child under 18 months. So really excited to be telling people about that. And apparently will also be available in French in early 2025. And then this would not be, brand new information for you, but a reminder that along that diagram or within that diagram, there is a role for that specialist consultation and care. And so examples would be what's offered at the Montfort and then through the Ottawa Hospital as well. And so I've included those as a reminder. And lastly, I often will, when I'm speaking with people, just a reminder that they can share this type of information with their clients and patients as well. Just to get that word out, we have the 988 number, and that it can be part of somebody's safety plan, that they have that number, that they know. So I include that here as well as a reminder and an example of sort of that planning and acute and crisis care. And I think that that's it for me. So I will let Jasmine have it back.
Thank you, Beth. Okay, so sometimes it's hard to know, like we're talking about all these step care interventions, but what do we as clinicians recommend that you do for any given kind of diagnosis or clinical entity? And keep in mind, I'm approaching this from a medical perspective as a psychiatrist, and that may or may not always apply to your perspective, especially coming from the client perspective. Ultimately, meeting a person where they're at is the most important and trauma-informed way of doing things. But in terms of what is evidence-based and what is most likely to have successful impact, self-help is almost going to help with anybody except for somebody that's in a severe episode. So a severe depressive episode or an acute postpartum psychosis. For those two clinical entities, really medication is what's going to pull somebody back from, and I will add ECT as well, is a possibility, although typically we'll be going to medication. This is something that's not going to, people are not cognitively in a place where they can benefit from any kinds of community resources, whether self-directed or delivered by a therapist or clinician. Bipolar disorder as well ultimately will always require medication to manage the chronic, to manage the acute issues and provide a stability and a baseline from which more work can be done, all including self-help, peer support, guided self-help, and structured therapy. For baby blues, again, this is not a clinical entity, and so people can benefit from education and guided self-help and peer support, but really this is a normative experience and not something that's considered a clinical entity. For adjustment disorder and mild depression, I would actually suggest structured therapies. And postponing the addition of medication until we get to a more moderate depressive episode, at which point both therapy and medication might be useful. And I've indicated the kinds of structured therapies that are useful for different diagnoses. But in the next slide, I'll go into each of those a little bit more in detail about what they are. So if I could have the next slide, please. Thank you. All right. So we talk about, you probably have heard a lot about cognitive behavioral therapy and, therapy in general. But what do we mean when we say that? Well, you know, there's hundreds, literally hundreds of different kinds of psychotherapy. When we recommend a psychotherapy, it would generally be one that has been studied and shown to have efficacy for the indication that it's being that it's been developed for, or that it's being talked about. And so for depression, these three modalities are among several, but the main modalities that have evidence for depression and perinatal depression in particular. And yes, I mentioned ECT before, and just to clarify, I did mean electroconvulsive therapy, to clarify. Thanks for that. So cognitive behavioral therapy, this is usually the classic therapy is 12 sessions, 1 hour each, usually a week apart. And the basic premise of CBT is that when we are depressed, we have depressive type thoughts like, I'm no good, people don't like me, the future holds nothing good. And those thoughts will affect how we behave in the world. And then it's almost like you sort of manifest what you're thinking. And so by behaving in a way that reflects those negative thoughts, that reinforces the negative mood, because you elicit negative reactions from other people, or you sort of seeing the world through, instead of rose-colored glasses, depression-colored glasses. And so the work of CBT is actually to take those glasses off, not to convince you that life is rosy, but to give you a more balanced view of life has negative aspects and positive aspects, and to have you have a more balanced view. And therefore, with that balanced view, experiment with more behaviors that reflect that balanced view, instead of the negatively depressive, tilted thoughts. And so that is the work of CBT. Interpersonal psychotherapy, or IPT, is an interesting modality where, instead of focusing on thoughts, it focuses on social relationships. Certainly the pandemic has taught us that people need people. We don't do well when we're in isolation, and it doesn't take a pandemic to create social isolation. Having any kind of life changes, moving, immigrating, divorcing, having a baby, will change one's communities. Even if it's a positive change, it will change one's community, not necessarily for the better, and erode the supports that you may typically have had when you were healthy. And so when you don't have the supports that you need, the illness that results from that is clinical depression. Just like if you don't have enough water, you get dehydration. If you don't have enough food, you get malnutrition. If you don't have a positive social support network, you get clinical depression. And once you have clinical depression, the symptoms of, withdrawing from people and feeling more sensitive to rejection, being more irritable, make it even harder to ask for help. So the work in IPT is sort of taking stock of who's in your community and how to ask for that help and that mutual support, even though it's really, really challenging to do that, given the mindset that you're experiencing and the tentative nature of your ability to relate socially in an acute episode. Mindfulness-based cognitive therapy, MBCT, is something that is really building in evidence, and I think is going to, in the future, have a major role to play for perinatal depression. That takes the best of cognitive behavioral therapy and adds it to mindfulness-based stress reduction. And so the idea is that, we're, as human beings, we're still animals, we're still mammals, but compared to all other animals in the world, we spend all of our time in our frontal lobe thinking about things. And we think and we think and we think, and we even think about our feelings. And we do so much of that we forget about the rest of our body and the environment that we are in. And so what the work of MBCT is trying to do is to reconnect us with our bodily experience and the environment that we are in the here and now. And by doing that, it helps to put into perspective the role of the thoughts and the emotions that we're feeling into this wider experience, so that with the wider experience, it takes on less valence or less importance overall. And so you're able to move forward with your, just even your day, let alone your feelings and your function, while keeping these depressive thoughts in your experience as a small part of your entire experience. So happy to answer more questions about that therapy, but I thought it would be important to kind of distinguish between the different types. I'll move into talking about medications at this point. You know, mostly I think we're a non-prescribing crowd on this webinar, but everybody in the healthcare team really plays a very important role in this, whether you're the prescribing provider or not. Women are so reluctant to take medications during their pregnancy or if they are breastfeeding. And often we have a lot of data that shows the actual safety of antidepressant use during this period. There are some general principles that we say, so keep it simple. If we can use one medication that has, you know, that is not just an antidepressant, but it helps you sleep or it may help your appetite, we try to do it in one rather than having 2 or 3 different medications at the same time, and therefore multiple exposures to the fetus. We don't want, this is not a time where we want to experiment. And if we know that a medication worked and is reasonably, and the risks and benefits outweigh, you know, the risks and benefits of not treating, then we want to go with that rather than trying to get a safer medication, because we don't want to waste time and we don't want to have multiple exposures for the baby. If we are choosing to take a medication, it's really important to optimizing the dose. We don't have evidence that a lower dose of a medication is going to be less harmful to the baby than a higher dose, as long as we're talking about therapeutic range. So I'll often see people that have, you know, sort of pulled their antidepressant back to like the bare minimum that's keeping them, you know, out of bed, but they're still experiencing symptoms. To my mind, at that point, then you're exposing the baby not only to the medication, but also to symptoms of untreated disease. And that's not what we want. We want to eliminate that exposure to symptoms of the disease for all the reasons that we talked about in the beginning and the risks that untreated disease carries to baby. Timing of exposure matters. During the first trimester, that's when the baby's organs are forming. So if we're going to try to minimize any risks to the baby, it would be during the first trimester. If a baby's already been exposed, then discontinuing it at 12 or 13 weeks when you realize that you're pregnant really doesn't have any benefit, because the exposure during those critical weeks of development has already occurred. I think one thing that we don't do a great job of is we talk all about the risks of medications, but we don't talk about the risks of the untreated disease. And so again, on that early slide that I showed you, it's really important for people to recognize that they're not just taking, you know, a medication that is optional here. They're actually doing their child and their extended family good by removing the exposure to untreated disease. And so that's really important for people to understand. In an ideal world, we would have no depression and therefore no antidepressants, but that's not an option here. So given that there is depression, what can we do to mitigate the risks of that disease? And then you may do all the work and have all the conversations with your client as you can, but then they go home and they talk to their mom or their partner or their mother-in-law, and they're completely convinced of not taking the medication. So at this point in the game, it's really important to get the partners and families on board to appreciate the role, because women are already feeling so guilty for having to use this medication that it doesn't take much for them to choose not. And you would be surprised at how frequently women are hiding the medications that they're taking from the rest of their families to avoid any negative blowback. So on this slide, we are talking about first-line treatment options for depression, and these are the same as before. In particular, I really like sertraline and escitalopram. And I've given some starting doses and titration schedules there. It's important to note that during pregnancy, the usual therapeutic range may not be sufficient to fully achieve remission. You may need to go higher than the usual therapeutic dose because there's more blood volume, the kidneys are working harder, the liver is working harder, there's more weight of distribution. And so often we're needing doses that are slightly higher than the usual therapeutic maximum for non-pregnant individuals. There's some interactions that I would highlight. Certainly with escitalopram, we want to be careful about QTC prolongation. So if you do need to go at those higher doses, make sure that you're monitoring the ECG. And that if a person is on domperidone also prolongs the QTC interval. So you would want to monitor the ECG of co-administering with an antidepressant. And just for those that aren't aware of what I'm talking about, this is when you look at an ECG and you look at the sort of pattern that's generated, some of these antidepressants and domperidone can actually stretch the ECG out so that one of the points that we call the QTC interval is stretched out. When it's too stretched out, it can precipitate heart arrhythmias. So that's really important to monitor. And of course, abruptly discontinuing any medication can precipitate not only psychiatric symptoms, but also symptoms of withdrawal. So I've also listed a few of our second line treatments, and these charts are available on our website, askmasi.com. And just keeping a plug out for the upcoming guidelines from the Society of Obstetrics and Gynecology of Canada and CANMAT, the psychiatry guidelines body, that are going to be released and that we're going to be highlighting in our upcoming course conference, which we'll give you some details on later. Just to highlight that paroxetine can be associated with more risk of poor neonatal adaptation syndrome. So any antidepressant exposure during pregnancy has a 1 in 10 chance of that fetus experiencing essentially what we think of as a withdrawal syndrome. So what that looks like in adults is they can feel like they've got the flu, like a little bit of malaise and headaches, brain zaps, sometimes people talk about. In babies, what that looks like is fine tremors bilaterally, irritability, a high-pitched cry, maybe some irregular breathing patterns, and that can also, oh, we lost the slide there. That can also, that's usually self-limited and lasts a maximum of 2 weeks. There are more severe forms of withdrawal where instead of just tremors and breathing irregularities, they might have actual generalized tonic-clonic seizures and require breathing support, but that is extremely rare. In my clinical practice, it's people that I need to keep on very, very high doses, even off these labels. And if they were not on those medications, they would be in hospital. They're usually on multiple different medications. So this is not the garden variety of neonatal adaptation. And another reminder that bupropion or Wellbutrin is contraindicated if there's a history of seizures or bulimia, because it can lower the seizure threshold. And I can talk more about meds later, but I'll leave it at that. Beth, I don't know if you wanted to talk about this slide again.
I can, yeah. So this is a diagram or an image that we've borrowed from NCPAP for Moms, Lifeline for Moms in the United States. And we use it in a lot of our slide decks to really just try to depict what it is we're hoping to do with the support of Ask Masi. And so it depicts a little bit of what care as usual tends to look like right now versus the outcomes that we hope to see with Ask Masi. So along the top, it just depicts somebody named Maya who notices this change in her mood at 14 weeks. And in this case, we've used an OB as the example, but it doesn't have to be the OB. It really is that to sort of demonstrate that this OB or midwife or family physician, just may not feel sure about how to respond, and may even, be nervous about asking the questions because not really sure what to do with that information or what the next steps would be. So in this case, this OB isn't really very sure about what next steps to take, so just takes a bit of a watch and wait approach. But Maya unfortunately feels worse at 28 weeks, and her EPDS score is 17. And so a referral is made, in this case to the perinatal mental health clinic, but could be to any kind of specialist. Unfortunately, we know about long wait period, so this clinic has a long wait. And at 1 month postpartum, Maya develops a psychosis. And as you can see on the slide, then that leads to some pretty poor outcomes for her and for her baby. What we hope to see with Ask Masi, and we again always invite you to share the word within your teams and to your colleagues, is that through education and training and even us going out to work with practices, that Maya's OB in this case knows about Ask Masi. Might be even, comfortable to do some screening, and might contact us at that earlier stage. We would provide some different resources, some community resources, potentially connect this provider with Dr. Gandhi, and they could talk a little bit around prescribing if that was relevant and appropriate. And so with that earlier intervention, by 18 weeks in this case, Maya's connected to a therapist, and she started in a support group, peer support. And by 30 weeks, she's feeling better. She's got remission of these symptoms, and she's adjusting well to life with her new baby. And so a lot about that is that early intervention and connecting people with the right resources at the right level at the right time. And so that's why we tend to use this image when we're giving these presentations. I'll just highlight an example to give you a sense of how it works. We want to save time for a couple of questions, but this is a call that we received. It was a midwife who called us. It was a patient or a client who was in their late 20s. They were a university student. It was their first baby. They were 37 weeks, and they were in Ottawa, but their partner was in a different city. So they had done the EPDS, and we actually knew that they had been on a medication, but they stopped it when they were 22 weeks pregnant. And so as a result of that conversation that we had, I did share some information about Ask Masi that could be given to the nurse practitioner for this particular patient. And I actually do think then a little while later that nurse practitioner did call us and chatted around the medications, but also talked and gave information on Family Services Ottawa and the Beyond the Baby Blues information about a peer support group and an article about antidepressants in pregnancy and lactation. So that's just an example of the type of thing that may occur with Ask Masi when people contact us, and an example of depression and how we could kind of try to support that through what we offer. Hand it back to Jasmine.
We, if you capture this VR code, it will give you our contact information. This QR code will put it right into your phone. And so, please feel free to call us. There's our phone number. We're open all Monday to Friday business hours, and there's our website. You can email us as well. Curious how people's practice, how they think they might change, and if there's any increase in confidence in identifying concerns or supporting people after having heard us talk. Give you a second to answer those poll questions. All right, wow, I'm so excited. 67% feel very confident, and 44% feel somewhat confident. Nobody is feeling not at all confident. Excellent, we're doing some good education here. And 33% have moved into the very confident to support their patients and clients with depression, and 67% feel somewhat confident. That's excellent. Thank you so much. We really are here to be available to you, not just in didactic format like this, but sort of at the elbow support when you need it. And a last poll question: after this webinar, do you plan to make any adjustments to your current practice? And you can check all that apply. And so when we're looking at the options, let's see the answers. People will ask, 76% of people will ask about symptoms of depression. 88% will use screening tools. I love it, like EPDS and MBQ. 53% will use a step care approach. This is amazing. And 94% of us will call Ask Masi. This is stuff I love. At this point, only 6% are not planning to make any changes and 18% have other ideas. So very great. Thank you so much for answering those polls. And then just in our next slide, I want to highlight that our course that I refer to is happening on Friday, October 18th. It's at the Civic Hospital in the amphitheater from 8 a.m. to 12 p.m. And we're going to be having the authors of the Society of Obstetrics and Gynecology, as well as the CANMAT, Canadian Association Network of Mood and Anxiety Treatments. I can't remember what that acronym always stands for, but the psychiatry guidelines are coming out for perinatal mental health. These are the first Canadian guidelines on perinatal mental health from both the obstetrics body as well as the psychiatry body, and the authors are coming to speak to us directly. We're really excited to be the first location to hold this joint launch. So early bird registration closes on Friday, and then the rates go up. So we really hope to see you all there, and the link is in the chat. And I think we'll leave this slide open but open up to questions while we round out the hour.
Yes, well, I just wanted to say thank you so much, Jasmine, for this great webinar. I will invite Christina if she wants to do questions and answer. I don't see any in the questions and answer box, but maybe Christina, if you just want to take a few more minutes just for closing remarks.
Yeah, I don't see any questions yet either, and it's fine because sometimes people need a little bit of time to process. So you know how to get a hold of Ask Masi. You've seen Beth and Jasmine here. They're excited to take your calls, and you know, these examples, I think everyone's learning here together. CMNRP has certainly been so happy to be a partner on you know, supporting the development and implementation of Ask Masi. And you know, you can just see the rich experience that we already have. We just had the 1-year birthday party. I saw that email from Beth, so congratulations, 1 year. You know, I think I love listening to you, Jasmine, when you talk about stuff. It's just you explain things so practically and so clearly in terms of taking some complex psychiatric medicine concepts and just like making that accessible to all of us. So thank you so much. Do look at the webinars to go back for more information about anxiety. That was an excellent webinar as well. And look at the Ask Masi website. There's constantly new information on the website. So click through all the tabs and just kind of see what's available for you. Now, there's a question about Ask Masi for any healthcare provider in Ontario. So Jasmine, do you want to answer that?
Yeah, absolutely. So we are available to speak to anybody in Ontario and Nunavut, with the caveat that the resources that we have access to, we specialize in the Ontario East region, healthcare region. So that's where we have maybe more. Beth certainly has things that are widely available across Canada on the internet, and the psychiatry piece doesn't change. So happy to take calls from anywhere in Ontario and in Nunavut as well.
Thank you so much. Yes, and there was a question in the chat about the next webinar. So we have the Francophone webinar equivalent of this session. And then in terms of the English series, the last one is about ADHD. So on December 9th. So we can put that link back in the chat box there. Registration's open for that. And we do hope that you're going to come on October 18th. This is very, very exciting. We are going to be having a great dialogue, and we've really asked the presenters to talk about, you know, some high level recommendations. Obviously, they don't have time to go into all the details, but you know, it's like implementation considerations. So what does that look like for you who are providing support and potentially intervention for families? So, you know, we're going to have a panel discussion about that. And then to close off the morning, we actually have a showcase again of community panel presenters, you know, so again, very specific examples of a variety of different services and supports for families. So it's going to be a great session. We really hope that you can come. It's in person. We've wanted a long time to come in person. So hopefully you're able to come here to Ottawa. So I don't see any more questions or comments. I just, on behalf of the whole CMNRP team, I just want to thank you both so much. It's a pleasure to work with you and to collaborate on these information sessions. In the survey, you see the link for the survey. We will appreciate your feedback and suggestions for other topics. So we're already starting to make plans about a future series. So we do need your input on what you think would be most helpful, and then the team can get to work in terms of making that happen. So thank you everyone for joining us, and tell all your friends about these upcoming events. And Catherine, thank you so much for hosting today's webinar for us.
My pleasure. Thank you.
Thanks, everybody.